Hello and welcome. Thank you for joining us this afternoon. My name is Cheryl Gagne and I'm a senior associate at C4 Innovations, and I will be hosting this webinar this afternoon on eliminating role confusion among peers, community health workers, and clinicians. Next slide, please. This is a presentation of the Opioid Response Network. SAMHSA's State Targeted Response Technical Assistance created ORN to assist grantees and other organizations to provide resources, technical assistance, training, whatever it is that organizations and individuals need to address their local opioid crisis. And technical assistance is available to support evidence-based prevention, treatment, and recovery from opioid use disorders. There'll be information on the last slide about how to request technical assistance. Next, please. So the ORN, the Opioid Response Network, provides local experienced consultants in prevention, treatment, and recovery to communities and organizations to address this crisis. We do accept, or ORN accepts requests for training, and that each state or territory has a designated team led by a regional technology transfer specialist who's expert in implementing evidence-based practices. And then to ask questions or submit a technical assistance request, this is where you go. It's very simple. The web address is the opioidresponsenetwork.org. Okay. Today we're so lucky to have two great presenters with us. We have, go ahead, next slide. We have Jamie Berberena from Community Health Work, who is a community health worker and kind of a leader and a shaker in the world of community health from New Bedford, Massachusetts. And we have Rebecca Zwiecker, who's a program director at No One Walks Alone Peer Recovery Service Center. She's also the owner and supervisor of that. She works with the Worcester Police Department. They can tell you more about themselves. Go ahead when they introduce themselves at their point. Next slide, please. Yeah, so just to kind of clarify from a definition point of view, a peer specialist or a peer recovery coach, and there are 100 other names they're often called, just to add to the confusion, is a frontline public health worker who has personal lived experience and uses those experiences to support others in their recovery journey. And that's really the key element of a peer specialist, peer recovery coach. Not only do they have lived experience, but they've received special training so that they can provide that peer support to other people in need. Likewise, a community health worker is a frontline public health worker who's a trusted member of the community or has an unusually close understanding of the community served. So intimate involvement with the community. They may or may not share the same sort of underlying medical diagnosis of the person, but they really know the neighborhood that the person is living in or the community that they're living in. Next slide, please. So there are a lot of similarities. And if we look at job descriptions, you probably see a lot of overlap. And in fact, it even becomes more complicated as peer specialists may address medical issues, and community health workers often encounter behavioral health issues in their work. But the credentials are different. They both serve as a bridge or linkage to resource. That's a very important role they do, is really link people to needed resources, act as navigators between the clinic and community, try to help remove barriers that may exist to accessing services or other resources, provide advocacy. I think most importantly, inspiring hope, by, acknowledging the difficulty a person is going through, but inspiring them that life could be different. lot of education may happen. They may provide transportation. They really get involved, and it's not just about the diagnosis at all. It's really about, supporting goals for a meaningful life. Most community health workers and peer specialists, peer recovery coaches work with vulnerable populations, mostly people who have been marginalized either from poverty, discrimination, diagnosis. They possess qualities of transparency, trust, empathy. They're vested and invested, right? So they're trustworthy people who connect with people in trouble or people experiencing difficulty. They'll use and share their own stories, and it might be based on their own lived experience or lived experience of someone else they're close with. At the same time, they use evidence-based practices and ideally reflect the communities that they serve, right? So speak the language and reflect the culture of the community that they serve. Next slide, please. Oh, and I'm going to introduce my speaker, Rebecca Zwiecker, who has done a number of presentations for us before. This is where we start. And Rebecca, I'll let you take it away to talk about peer recovery coaching and your work. Go ahead, Rebecca.
Thank you, Cheryl. Hi, everyone. I'm very excited to be here today. My name is Rebecca Zwiecker, and I am a woman in long-term recovery. And what that means to me is that I have not had a substance in my body since June of 2014. At that day, I did not know I was going to come into recovery, and this was going to be my journey. However, that's how my journey ended up starting through the criminal justice system. I always like to share some of my pictures from my active addiction, just to get a look at like, who I am today in recovery and where my addiction had brought me to. On the left, those are my 6 mugshots from the Worcester Police Department. And on the right is a picture where I had a visit with my family in active addiction. And, when I look back, I didn't realize where my life was at with my addiction. And having these memories really keeps it up front for me to be able to see like, geez, recovery is amazing. And sometimes just sharing this with someone I'm working with can just be hope alone without any words explaining it, just to see the difference from my active addiction to today. So part of my work is I started a nonprofit with the Worcester Police Department, which is specifically around addiction recovery support. And they have assigned an officer 40 hours a week for this program, where recovery coaches are out in the community, as well as the officer who is crisis intervention team trained. And she's a certified addiction recovery coach, and she's an ally. Her daughter is in recovery and really shows compassion for people with substance use. You can go to the next slide. So I always like to share the amazing part of recovery and like living life to the fullest. On the bottom right, that is a picture of Judge Allard Madaus and myself. When that June 18th of 2014, he had sent me to 7-day MCI Framingham. I'm located in Massachusetts, and he had sent me there for 7 days for a detox. I do not promote incarceration for recovery in any way. However, where I was at in my life at that point, it was something that I needed to like bring me back to reality to see. And because of recovery and like doing recovery coaching, I ended up working in his court. He started a recovery drug court program in Worcester, and I was a recovery coach working with the participants. And we are still close friends today on the opposite side. Next slide. So for a recovery coach, for me, I went through the training I would say like early on in my recovery, a little over a year. I wasn't mentally, emotionally, physically like stable enough in my own personal recovery to actually become a recovery coach. I was working full time, but I still needed to get a little bit more foundation in my own personal lived experience of recovery before I could become like a profession. However, it gave me that motivation and that hope of like, in that passion of like what I wanted to do, because I just adapted what I learned going through the Recovery Coach Academy and all the additional trainings. And we're really about self-directed. It's what the person wants, and it's not what someone else or professional may think that the person may need. It's really self-directed by the person. We're very strength-based, focusing on the strengths. Someone has a setback in their recovery, we're not gonna say, oh geez, like what happened? We're gonna focus on like, wow, you know, for 3 months you did great. Like, how can I support you to get back to that? We empower individuals. We're like their cheerleaders on the side. The basic needs, recovery is not possible without meaning, purpose, and goals coming from within the individual. Something that I always think back to is I checked in the detox 150 times. In one facility, I went back to 69 times. And that's because they would say, welcome back, Rebecca. We're so glad to see you. Other facilities may have had their hand on their hip and say, geez, like you didn't follow the plan I gave you. So the ones that like welcome me with that non-judgmental and like, here, let's just try again. How can I support you? Were the ones that like I wanted to go back to because I felt welcome and like non-judgmental. We offer hope. And like I said, like sharing my active addiction pictures and then who I am today, or for other coaches, that optimism, you can do this. Many of us do. Recovery is possible. That positive self-identity, where recovery focused, not on disorder, and being of service and like giving back. Recovery coaches, a lot of recovery coaches started off in order in the state of Mass to get, we call it CARC, which is a certified addiction recovery coach, because it's a fairly new profession. And it's really blossomed over the past few years. A lot had to start off as like a volunteer to get those 500 hours to get certified. So being of service and giving back can really help someone in their recovery. Next slide. Peers, coaches, we're peer-based support, goal of engagement, we're compassionate, no matter how many times, the first time, the umpteenth time, how can I support you? It's that unconditional, we're non-judgmental, no matter how many times. And I bring it back to that detox of that one facility of checking in 69 times and, them saying, welcome back. That meant so much to me. Having that connection to a recovery community is huge. The opposite of addiction is connection. So really helping someone figure out what is that connection for the person. Building that trusting relationship, advocacy, having healthy boundaries. So we may be peers, but I'm not going to invite you into my household. I'm still a professional and there's boundaries, and really setting up those boundaries, not answering the phone at 2 a.m. There are hours that we work. One of the parts of recovery coaching is a recovery wellness plan, and it's a lot different than a clinical like treatment plan, because a recovery wellness plan is made by the individual, or we call them recoveries. And the coach is there to guide them and support them with that plan. And what happens is the person takes ownership because it's their plan. and they're motivated to do what those goals are because it's self-directed and it came from the person. And then recovery coaches working in like an agency organization, very important that they have a recovery coach supervisor. I know that there are not a lot of trained recovery coach supervisors in the state of Mass as of yet, and more are coming. And I know BSAS, Bureau of Substance Addiction Services, here in the state of Mass, have made it a requirement now that the recovery coach supervisor is someone with lived experience, because that way we're able to better support the individual. Recovery coach supervision is more about building a relationship. It's not about going through like a caseload or checking the boxes. It's more of like building that relationship, and you hear the person, they may be a little agitated, aggravated that day. We have that built relationship where we can check in and say, hey, like, what's going on? Like, how's your self-care? Have you had an opportunity for whatever their pathway of recovery is, and being comfortable to have those conversations. And we are non-clinical. So when it comes to other things that are outside of the addiction recovery language or topics that come up, we're very staying in our lane, and why it's important that the coach stays in our lane, because we're not trained in any type of like clinical or outside of our role, and being able to have that resource to guide that person to the appropriate care. Next slide. In places that you might find peers is recovery community centers, recovery support centers, emergency rooms. For me, I had, right before I was incarcerated on that last time in June by Judge Medaus, I had an overdose on the train. And when I woke up, I was in ICU, and it was 2.5 days later. And the way I was treated by a medical professional was because a lot of it had to do with stigma. And I was discharged in like a Johnny top, in the same shorts that I had soiled because I died when I overdosed. And, having a coach at bedside to be able to treat me with like compassion. I had the opportunity to work in that same ER a few years ago, and to meet with people post overdose and treat them with compassion, and like removing that barrier and providing them with donations of clothes or transportation. Child Protective Services here in the state of Mass, Department of Children and Families, and really specifically like we're mandated reporters. So it may look a little bit different working with a parent who has the Child Protective Services involved, or if we have to file, here we call it a 51A, if there is a concern of endangerment for the children, we do it with the person rather than like behind their back. And we always try to include with any other like team, we're there with them, and really supporting them to keep that trusting relationship. You can go to the next slide, and I believe it is, I think that's the last of it.
This is the last slide.
Yes, yep. So that's what I was just going over, the DCF or here in the state of Mass, that we do that together, that we report it and come up with a plan rather than calling the Department of Children and Families behind the person's back, that we're going to do that with them. And also outpatient clinics, we would, a lot of times we may have a outpatient therapist reach out to us and say, one of my clients is struggling with addiction and not too sure what type of resources. and really including that person. And it could be the three of us meet together, the recovery coach, the individual being served, and the clinician, and really helping them to sort out what that plan may look like.
Thank you so much, Rebecca. That was such a nice job describing peer recovery coaches. And we're happy now to have Jamie Berberena present on community health workers. Thank you, Jamie.
Thank you, Cheryl. So my name is Jamie Berberena, and I have been a community health worker for well over 10 years. I began this role at a young age, interpreting during medical visits for my dear grandmother, who only spoke Spanish. And today I'm a certified medical interpreter. Over the last decade, I've had the opportunity to serve as a leader and advocate on behalf of the community health worker workforce. Within my role at the state association, MACHWA, which is the Massachusetts Association of Community Health Workers, I've been actively supporting sustained policy changes in healthcare reform, and I've been an advocate on behalf of the community health workers. So I'll just briefly, the slide here is from the American Public Health Association, and I will just briefly give you the definition of community health workers, who are frontline public health professionals who are trusted members of and have a close understanding of the community served. They're members of a target population and we understand our community's culture and language is spoken. In our role as health professionals, we have specialized training to provide health education, often working alongside medical professionals to address prevalent health issues and helping patients with complex health conditions navigate healthcare systems. Next slide, please. So, community health workers, we have many titles, but our core work is the same. We live and work in various settings, tribal, rural, and urban, to mention a few. Community health workers build individual and community capacity by increasing health knowledge and self-sufficiency through a range of activities such as community outreach, health education, informal counseling, advocacy, and social support that addresses the social determinants of health. Next slide, please. Okay, one moment. I'm having some problems getting to my slide. My apologies. One second, technical difficulties here. Okay, here we go. So the slide speaks for itself. It mentions that CHWs are powerful drivers that decrease costs, especially among patients with high starting healthcare costs and among underserved minority populations. Next slide, please. So here are some points for an effective community health worker models of care. Effective models of care allow community health workers to address the social factors and in turn improve health outcomes while reducing healthcare costs and advancing health equity. These are the main points. They're evidence-based interventions, upstream approach to care management, address social determinants of health, improve health outcomes, reduce costs, and promote health equity. And that came from the Center for Disease Control. Next slide, please. So here are 10, here we go, thank you. 10 core competencies for community health workers. The Board of Certification of Community Health Workers at the Massachusetts Department of Public Health established these 10 core competencies. Standardized core competencies are important for addressing health disparities, maximizing community health worker effectiveness, and further establishing CHWs as health professionals. Moreover, a workforce framework is beneficial for describing, scopes of practice and directing training for community health workers, diverse roles and work settings. Next slide, please. And here are the 10 Code of Ethics. The Code of Ethics was established by the Massachusetts Association of Community Health Workers, and it serves as a guide to CHWs for day-to-day decision-making while practicing public health work. Its purpose is to clarify the mission, values, and principles of the profession and to link these to specific standards of professional conduct. The code is meant to complement existing employer policies. Thank you. And now we'll talk a little bit about class standards. So there are national established class standards. Community health workers adhere to class standards to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. Class is about respect and responsiveness. Respect the whole individual and respond to the individual's health needs and preferences. Class is a way to improve the quality of services provided to all individuals, which will ultimately help reduce health disparities and achieve health equity. Next slide, please. And here are some key points to clinicians and CHWs working as partners in patient care. CHWs serve as an intermediary that support clinical providers improve patient care. They are active members of care teams that seek solutions for community members who may be experiencing barriers to healthcare. They understand role boundaries of not giving clinical advice, and they are culturally competent and increase patient self-efficacy to achieve positive health outcomes. So community health workers are basically the link and the communicator that works hand in hand with community and clinical providers to help patients reach their goals and overcoming social determinants of health that often interfere with a successful health outcome. So thank you, and I can take questions. I don't know if questions are now or we're waiting till the end.
We'll take questions in just a moment. First, I want to introduce Mira Herrera to everyone. Mira, I don't know if you want to come on camera and talk about your work with community health workers and community ambassadors.
Yeah, thank you, Cheryl. I don't know, I started my camera. I don't see myself still. I don't know if you guys can or not. Not sure how well that works.
We'll get you up there.
Okay, awesome. And also with me today here is Maureen Nichols. She is from the Texas. Oh, there you go. I can see myself now. Great. So Maureen Nichols is also here. She's from the ATTC in Texas. She's also been working on this pilot that I will be discussing with you today about the collaboration of peer support specialists and community health workers. So I'm Maureen, would you like to introduce yourself? I think she's able to yet. Okay. 1 second. We'll get to her. To speak. So until we get that, so as I said, my name is Mirna Herrera. I am actually in Kansas City, Missouri. I work at Truman Medical Center. We're part of the behavioral health. So at Truman Medical Center, behavioral health and is part of the hospital system. So we have a big collaboration with that. It's with the both sides of the healthcare system. So what we do, the ATTC and SAMHSA have been working on developing this model. We're calling it the Community Health and Wellness Ambassador Model. They've been working on this for 4 years. Oh, I see Maureen is here. Yeah, Maureen, how long have you been working on this model for the CHWA?
I think it first came up in 2015. So it's been an ongoing project. Mhm.
Yes. So what this project, the gist of it is, it started off as a conversation between like what we're doing right here, talking about more about what CHWs do, what peer supports do, and seeing the similarities as we just seen between the two professions, and trying to figure out what can we do to work together and collaborate more. And coming straight from the peer support world, myself, I'm a peer as well. I'm also a peer trainer. I do the certification trainings here in Missouri. We were thinking about about all the work that the CHWs do at the hospital and how the skills that the CHWs do would be such a great addition, such a great complement to the skills they gain in their certification as peer specialists. So some of the model has been evolving, as I said, like for almost 5-6 years right now, and the model that was created, as you can see on the screen, especially if you go, yeah, so this talk, best separate was this umbrella, almost scroll a little bit more. Yep. So what we're hoping to do is having a peer specialist get the certifications for community health workers. And we say specifically peer specialists to start getting that training because in theory, all peer specialists can have because they have lived experience, they can also become a community health worker. Not all community health workers can become a peer specialist depending on their lived experience with a behavioral health disorder. So that's why we're also and in the pilot we're doing at Truman, we're coming at it from the peer support part of it. So as you can see here, the ambassador, what we're talking about is, when you have an ambassador, then all of the, it's the combination of all of these um, titles, if you would say, or all of this skills that you can have. And I know in Missouri we call them a peer support specialist, and other places they call recovery advocates. So there's a lot of different things. In Missouri, the other thing that in Missouri is that the certification training actually is an umbrella for both SUD, substance use peer specialist, and mental health peer specialist. So we don't have a separate certification; they're all under the behavioral health umbrella. So it's not like, that's why it will be more of a combined skills for that certification training. Maureen, did you want to add anything for the model before we talk about the pilot?
No, beyond just to say that this model came out actually of a conversation that happened in 2018 with a group of about 30 community health workers and peer specialists that were in a room together, just kind of like the folks that are here on this webinar. And we were just talking about how the two or the fields might work together. And what happened is, in the course of the conversations, they spontaneously developed a integrated model. And this just came out of the conversation, and the group that was there felt very passionate about the collective strength of the two fields trying something like this, and built this on the spot on a whiteboard. And so we have since, as a larger group, and these were community health workers and peer specialists from regions 5, 6, and 7, which essentially is the middle of the country, north and south, the Midwest, the central Midwest, and then our region with Texas, Oklahoma, Arkansas, Louisiana. We have been working on a way to pilot it and see if we can put something forward and do a little research and see if we can look at outcomes. And so that's what Myrna has taken on, is this attempt of this first pilot of this model that spontaneously came about from that meeting.
Thanks, Doreen. So yes, as Maureen was saying, it's become more of a model of a career advancement. So for us to because with peer specialists, at least I'm talking about with Missouri. I know a lot of different places have different career opportunities, but at least in Missouri, when you're a peer specialist, there's not really any other advancements beyond that. You can do other job titles, maybe management in the peer world, but that's why I think in adding that would be an added career ladder, if you would say that, call it for peers. So what we decided to do at Truman, this has started even pre-COVID, Brian, these conversations. So that's what we wanted to do, is try to pilot this, take a few of the peer specialists already employed and the behavioral health department, get them trained as community health workers, and then provide services to a group of people, and then see what the difference would be in those services and the outcomes. COVID hit, and then that opened up even more opportunities for us. Some more recent data from researchers come out with some statistics that says 1 in 5 people who are experiencing COVID develop some sort of a behavioral health disorder, whether a mental health issue or a substance use issue, within the first 90 days. And then at the same time, 1 in 3 people develop some sort of long-lasting physical health issue complication that they will have to learn how to navigate the healthcare system or the behavioral health system. So there's new population emerging that needs those services, need to learn how to navigate the systems, needs to just be able to assist them in the recovery process from whatever they can help them with. So that's what we decided to focus on at Truman, is that population of those COVID survivors who need that additional assistance, to assign ambassadors to them so they can help them as a whole. Because with peer specialists, we help them behavioral health. With community health workers, we help them more with their physical health and their culture. So now when we have the ambassador, they can help them as a whole person, navigating both systems, in order to be able to focus on combination of what you guys focus on, like what peer specialists focus on, and the community health workers, health activation, developing recovery capital, connecting with resources, health literacy, all of those things, that combination now would serve the person as a whole. We're in the final stages to get some final fundings to be able to find those people, start working with them. Maureen from the ITCCs, they're evaluating our pilot too, so we're hoping to be an official pilot that proves the concept. We're also going to look at the job satisfactions of peer specialists, and how having that career opportunity advancement and more skills gained, hopefully it will improve this job satisfaction. We know there's a lot of turnover in peer support world, so hopefully that will help with that too. And then in return, how it will help the organization, instead of hiring 2 people, hiring 1, because there's already hiring shortages in both professions. Hire 1 person that can provide both services, or just saving on cost in general. As I think JV, you were saying, how community health workers, they drive cost savings for hospitals. So we're hoping to get some data for that, and how we can help the patient served, and the organization and the peer specialist at the same time with that one. So yeah, Maureen, did you want to add anything?
No, you did a great job. So we're excited about the pilot. It's been a journey over the past 5 or 6 years that we really didn't start out with a specific goal. We just started having conversations and building relationships. And we're excited it's landed to a funded pilot, and we look forward to testing it out, see how it goes.
Yes, exciting opportunity. And I would add, like, we already have some interest from funders, from health insurance companies, because they want the data so that they can offer reimbursable services for community health workers and peer specialists. In Missouri, we already have some reimbursable rates for peer specialists that are a good rate, but CHW works, we still don't have those reimbursable rates. So we're hoping by getting more data, we'll be able to advocate for those. And this is not only Missouri. I know reimbursable rates also in general nationwide as an issue. So we're hoping that data will generate more of those conversations with funders to be able to get more of those reimbursable rates so that we can start working and not rely only on grants to provide these services. Yeah.
Thank you so much, Mira.
Yes.
Thank you for
thank you.
presenting this. It's exciting to see the fields kind of coming together. We do understand that for many people with mental illness, as they age, they have, serious physical health needs, and navigating medical settings is challenging. And likewise, people who've lived with chronic health conditions are much more susceptible to substance use and mental health disorders. So it's good to be kind of dually competent, and we're seeing that in a lot of arenas. I want to ask a question of both Jamie and Rebecca about kind of your training, both the foundational training. What were the key skills that you remember, like, were really hammered home? And, what sort of continuing education training do you find yourself hungry for? So I guess we can start with you, Jamie, if that's okay.
Fine. Can you hear me well?
Yes.
Okay, great. So the key training was related to addressing chronic conditions, preventable conditions. And so I became a trainer in that area and worked on a variety of health issues and worked on building resiliency and motivational interviewing with the population. I did a couple trainings in Spanish as well, and I became one of the leaders that was able to train other community health workers, so like the train the trainer situation. I've also done some training around core competency, because in the state it's required that 60% of the course is trained by co-led by a community health worker. So I've had the opportunity to do that. I would say, for me, I felt I had the expertise straight off the bat, because I knew my community knew me, the trust was there, the love was there. It was just a matter of building that rapport and saying, oh, you've got this going on, keeping it basic, taking steps with them to help them achieve their goals in a realistic manner. And also addressing things that might be, intervening, such as housing or food insecurity. So just naturally knowing what the resources were and knowing your community and having that trust and speaking the language, because I'm very proud and honored that I began the role via my grandmother. So my grandmother really didn't speak English at all. And so I helped her navigate multiple systems, and it became my niche. And then I just continued to do so. And so I consider this work hard work. And for future training, I would love for community health workers to be present at more policy tables, like more leadership. I would love for community health workers to get fairly compensated for their roles, and making sure that they're integrated in all public health settings and that they have that sustainability and job security, because that hasn't really stuck in Massachusetts. And it's really hard to keep people invested in a role with high turnover because of the fact that it's not sustainable. There's a grant here, there's a grant there, and I know they're working on the reimbursements, which is really innovative, and I hope we can finally get there. But there's a lot of work that needs to be done as it relates to fair compensation.
Thank you. So some real advocacy, and because of where you're positioned in the system, you have really powerful ideas about policies and and policy implications. So yeah, a bunch of people nodding heads. What about you, Rebecca? What do you recall most about your training, and what are some things you're hungry for now that you're in the work?
I would say the biggest thing with the Recovery Coach Academy, altogether to get certified in the state of Mass, it's 80 hours of classroom training and then the 500 working hours. Going through that first 40-hour Recovery Coach Academy was really about meeting the person where they're at and having no expectation for their recovery. So you could see someone living in a tent, actively using, and like, you could see them and look at them and say, geez, like going into detox or getting on methadone or Suboxone may really help this person, but really just meeting them where they're at, physically, mentally, and using that motivational interviewing and offering that hope to bring them into recovery. That was very eye-opening and really, a lot of members in the recovery community, when people hear substance use, the automatic thing that comes to mind is 12-step meetings, that the person has to go to Alcoholics Anonymous or Narcotics Anonymous, and really being educated on the multiple pathways of recovery and learning about those so you can explain to someone else, like, oh, they have SMART recovery or fitness, yoga, meditation, medication-assisted treatment. And lastly is changing the language and not using the stigmatizing language. Because, when you approach someone, and if I was to talk today and refer to myself as an addict, there's a lot of negative thoughts that come behind that when someone hears the word addict. So if I'm calling someone, if I'm working with someone and I say, yeah, I was an addict or I am an addict, and I refer to them as that, that's really stigmatizing and makes someone feel like low, or using the words like, you need to do this or you should do this, in changing that language and saying, have you ever thought about going into detox? So I think that conversation piece, one of the things that we're working on with the Child Protective Services, with the caseworkers, is having these open Zoom meetings with the workers on how to have those difficult conversations about substance use, and like really involving the parent. What have you tried? What haven't you tried? Because a lot of them in the state of Mass, it's called an action plan, but include the person. Anything about us without us is not for us. So like if someone is making a plan about us and we're not included in it, it's probably a plan that may not work for us. So really about like that education piece about the multiple pathways in that stigmatizing language, and asking those really good questions that may be uncomfortable for some.
Yeah, thank you so much, Rebecca. I mean, it seems, the language of respect and acceptance and person to person, not oriented toward a diagnostic label, or just oriented person to person. That you both have mentioned motivational interviewing as being a tool that you might use. And as someone has had training and continues to try to improve and perfect, I know that's a skill set that it's a lifelong learning to really improve. And then the other thing you said, Jamie, was about kind of this chronic, that you studied sort of about chronic health conditions or chronic disease management, as they call it, model. which I think works really well with behavioral health too, if we think about, you know, substance use disorders or depression as a chronic health condition that we can manage and live well with, that's a framework. Yeah, I do want to put it out to the group if there are any other questions. A couple people shouted out that language is very important, you know, and to focus on that and be careful with that. Any other questions before we say goodbye and thank you? Yeah. There's one last question, I guess, and it's either for Rebecca or Jamie. In your work, have you ever encountered conflict with a clinical provider, just difference of opinion or even a power struggle? Rebecca's smiling. I don't know, put that out there. I don't want to emphasize the negative, but you know, it is a relatively new role to the field, and yeah, I'm kind of curious about that.
I would say I've encountered situations where I had to help educate providers as a cultural broker, where they might not have understood particular cultural practices or religious beliefs that hold strong and sometimes go against what their care plan might be. And so the whole non-compliant situation is a barrier that I think community health workers are constantly trying to overcome and educate the teams that they sit on.
Yeah, I love that you see yourself as a cultural broker, and let me introduce you to this. Let me help you understand that. And what a nice framework for what could be a conflict, right? Right, very compassionate. I don't know, Rebecca, have you had any challenges?
Yeah, a few. I think I've been doing this for about 4 years, and like when it really started to get bigger, the recovery coaching and starting off like part-time, you know, in the ER, in the emergency room setting, for instance, they typically have clinicians that are behavioral health who, if someone comes in post-overdose or substance use related and seeking a detox, almost being looked at like the recovery coach is here to do like our job and they're gonna like just take over, rather than like working collaboratively. So if someone is dual co-occurring and they need a hospital level of care, we're not going to go and say, oh no, they're post overdose, they need detox or medication assisted treatment. Let's work together. Like, we're not going to duplicate efforts. We want to work together as a team. So I think a lot of it is educating about the role, and really making it clear we are not clinical in any way. And we're always including the person in that plan. We're not going to tell them this is what you have to do. We want to support what that person wants to do. So really that education piece. When I started with Family Continuity, who is the host agency for the Recovery Center, I went to, this is obviously a few years ago, prior COVID, but I went to the team staff meetings where the clinical would meet and did a presentation on recovery coaching so they could get a better understanding of like what we do and have those conversations and questions like, oh, so I could send someone to you for this or for that. So they would understand like we're not coming in to like take over and replace anyone. We're an additional support so we can work together.
Yeah, thank you, Rebecca. Marina, I don't know if you have anything to add. I know that there have been some questions or comments mostly about community health workers and peer specialists' role with COVID and what your experience has been.
Well, I wanted to add something though, especially to what Rebecca was saying and the question of conflict. I think what I'm learning more and more is a lot of the time the conflict or the way the peer specialists are used is it's not because they don't want to work with them, it's because they just don't know. So we're really focusing on education, a lot more education and awareness of what do we do and how do we collaborate together, because we're not in competition against the treatment team. We essentially work together so that the person themselves can, engage in the recovery and get better. A lot of the times that conflict that I see is it's purely based, most of the time, purely based with that, like the not knowing exactly what to do. And that's why they don't know how to use a peer specialist. They don't know how to, what services they provide. Well, like they said, well, we're working with them on housing. How come you're working on housing? Or we're working with them on resources. How come you're also working on resources? But, just explaining that we come from a different point of view because, we ourselves have used those resources before. So we are coming from that point of view is, I know this resource, I've used it, I've noticed my recovery community, this is what helped me, let's see if that can help you too. So yeah, so a lot of that, as the education part of it has been a big part of this campaign and the pilot internally, even here, and hopefully, in presentations like this, I think is very important.
Yeah, and it makes sense that there would be growing pains in the system where we're working together and perhaps don't have decades of experience of collaborating. That those kind of rubs are real opportunities, though, for growth and development. And I think, we'll see a lot more of that. So I think Melissa would like to switch us back to the slides so that you can tell us about some upcoming ORN adventures. So this is an important topic, and it's integrating treatment and recovery supports into services for people experiencing homelessness. That's going to be on April 27th, which is a couple weeks, 3 weeks, 4 weeks from today, from 2 to 3. Important topic. We know that homelessness has, at least in my home city of Boston, has increased, and the need for integrated treatment and recovery. You'll all get a link for that, and we have some great speakers coming for that. I want to thank you all in attendance for your participation and thoughtful comments in the chat box. And I mostly want to thank our presenters. Rebecca, thank you so much, and Jamie. And Mira, thank you for coming on and telling us about the wellness, I was about to say umbrella, ambassador. The image really stuck in my head. The Wellness Ambassador program. We hope to see you at our next ORN presentation. Take care. Goodbye, everyone.